what's kind of the main reason that the findings that are clear already today are not used more broadly? So is it the price? So how much does pharmacogenomic testing cost, for example, in the US? Is it the fact that we maybe still do not know enough about this to be able to apply it to every single patient? So where do you see the biggest barriers to the broader use of pharmacogenomic testing before prescribing medications?
The cost of testing is certainly a barrier. Over the years that I have been doing pharmacogenomic implementation and application, I am seeing positive movement in this way. And let me just explain what I mean with that. So most of the pharmacogenomic testing that we use in clinical practice are so-called combinatory panels. It used to be years ago that we would test one or two genes, like for example, CYP2D6 or CYP2C19. These refer to cytochrome P450 enzymes 2D6 and 2C19. And the reasons were that they tend to be really polymorphic genes, meaning if you look at the room of 100 of us, at least about half of us are going to have mutations to those genes. So it would be important to know if you have a mutation on something like this or not, because these genes or enzymes are actually involved in metabolism of many drugs, many drugs. So we moved away from the single gene panels to now these combinatory panels. And the cost depends, but typically what I see is maybe a couple of $100, $300 or $400 for the panel that has maybe dozen or 20 or 30 different genes. And it's an eclectic list of genes. So it can be drug metabolizing enzymes, drug targets, drug transporters, maybe HLA genes that help us distinguish self from non-self that are involved in drug hypersensitivity reactions. The cost, actually, why I say this is what I'm seeing is a positive movement or movement in the right direction, is because as the number of genes included on these panels rises up, so we have more and more genes included, for which we actually have some solid evidence behind, meaning guidelines to support them, we are seeing also at the same time drop in terms of the cost of these panels. So patients are quite in tune with what has been going on. And as a matter of fact, patients or customers and healthcare consumers are kind of driving this conversation to say, should I have this genetic testing done, considering that maybe I can even afford it now as opposed to years ago. In addition to that, I'm also seeing, Tiasha, more insurance companies willing to pay and reimburse for this testing, which also then drives this at the point of care. That still remains a barrier. So the cost itself and reimbursement as well. There is a difference between Medicare versus the private payers and so on. The second big thing, of course, is genetic literacy still remains low, both in terms of healthcare providers and the greater community. The third thing would be we need these supportive tools for those of us who really bring this to the clinical practice. What are the supportive tools? Clinical decision support. I know a lot of institutions and community pharmacy settings as well are looking how to effectively build these clinical decision support systems that will enable effective and less disruptive to workflow integration of pharmacogenomic test results at the point of care. And so what that means is, like, for example, when I meet with a patient and the results come back, the results actually for our institution at least are automatically embedded in electronic health records where clinical decision support is built that either enables a physician or a prescriber to say, if I'm prescribing something, I may actually be alerted that this patient had genetic testing results, and there are some significant findings around drugs for which we have guidance, genotype-based guidance, that they may be alerted in a way that actually enables a personalized, if you will, prescribing of those medications. So these are just some of the factors, cost or reimbursement, genetic literacy remaining low, and these clinical integrative support tools that continue to evolve. Right now in pharmacogenomics world, we're really focused on pharmacokinetic studies. I think what I'm excited about that I'm seeing is these complex pharmacodynamic studies that can help us better understand serotonin receptors. We see that now with emergence of, even psilocybin therapy, which tend to be, years ago, we would not have had this conversation that we're having right now to say we're using psilocybin. But when you think about it, this has to do with serotonin network, at least that's what we think, serotonin receptors. So perhaps understanding all of this better can help us, determine what is the basis of all of this, what changes, and what perhaps drug targets could be of significance in years to come.